Today, I'm joined by Dr. Stephen Hauser, director of the Weill Institute of Neurosciences, University of California, San Francisco. He's been an MS researcher for several decades, has been a key figure in the development of B-cell depleting drugs for the treatment of MS, along with the important genetic studies of MS. Good to see you, Steve.
Brandon, great to be here.
So I recently read your book, The Face Laughs While the Brain Cries. And believe it or not, I was actually taking my daughter to a Barnes and Noble to look for children's books, and I was looking through the nonfiction section and I found it randomly. So fate brought me to your book, and I really enjoyed it. They really gave you the prime real estate there. And I appreciated it both as a memoir. You talk a lot about your personal life and the history of your development and your childhood, and also, of course, about the history of MS research. And it seems like you had a lot of early exposure to neurological disease. Your brother Howard had a significant developmental disability, and one of your childhood friends had brain cancer. Is that what got you interested in pursuing a career in neurology?
Yes, Brandon, when I began writing the book, I wanted to write a story of medical discovery that would interest the public, perhaps might increase the public's faith in science, especially as I was writing during COVID when there was all this disruption and questioning about scientific evidence. And I also wanted the book to be inspiring and maybe something that would help encourage young people to consider careers in medical science. And above all, I wanted it to be fun to read. But I began it as a story of scientific discovery because the advances that we've seen in MS are really among the great success stories of modern molecular medicine. And as I wrote, the story came together, and the publisher said, "This is an interesting story, but people don't care about the science unless they know the scientist." So they sent me back to add a memoir to the story of discovery. And that's how The Face Laughs came together. And as I wrote, it was also an amazing personal voyage of rediscovery for me because it became so evident that early life events shaped my future course in ways that weren't consciously in my mind during most of my career. As you say, I had a brother who was severely handicapped and who had a profound influence on me. A best friend with a brain tumor, my mom's best friend with, in retrospect, herpes encephalitis. I was personally tormented by immune diseases all my life with terrible asthma in New Orleans and New York and Boston, eczema, terrible itching of the skin, treated by allergists who at the time in the 1950s were not much different from alchemists. The science of immunology in the clinic was not advanced a couple of generations ago. And as I wrote, it became so clear that my direction towards becoming a physician of the immune and nervous system was almost preordained by my history. It was almost as if I didn't have any control over the matter.
So, when you were a junior doctor, one of your early patients, Andrea, is kind of the inspiration of the title of the book, which is an unusual title, The Face Laughs While the Brain Cries. Can you kind of explain, your experience with Andrea and the title a little bit?
Yes. In the book Shoeless Joe by Kinsella um, about Shoeless Joe Jackson, there's a statement made by an old baseball player, Midnight Graham, where he says, "One never knows when the most significant moment of your life is going to happen, and you don't recognize when it does happen immediately." But for me, it was Andrea. I was a 27-year-old medical resident at the Massachusetts General Hospital. She was a 27-year-old lawyer working in the Carter White House. She was unbelievably accomplished, gracious, um, kind, and over the course of about 6 weeks, developed the most ferocious course of multiple sclerosis that I or even my mentors had ever seen. And I remember seeing Andrea for the first time and thinking that this was the most unfair thing I had seen in medicine. So there was a confluence between a very important early medical experience with the experiences that I had gathered my whole life with immune and brain diseases that led me towards a career in MS research. And for people listening, and most of your audience knows this, MS usually presents as a lamb, not as a lion. So this was a very unusual event that struck Andrea, and is not the kind of devastating presentation of MS that happens in the vast majority of people.
So Andrea was an exceptional case. Certainly we do see people like her today, but, more typically, what was MS like in the 1970s? I started medical school in 2005. MRI was widely available. We knew a lot about MS. We had some treatment options. What was it like to try to diagnose MS without MRI and without any, at least, approved therapies? I know people had tried things like cyclophosphamide. What was it like in the wild, wild west?
Yeah, so there were no effective treatments for MS except steroids, and these barely worked. But I think even more important was that there was also a general pessimism among senior leaders in the field that we could find answers, or that even it was worth the effort to search for answers to MS. And this therapeutic nihilism that was present, I think, is in such sharp contrast to the optimism and success that we have today. I remember the first national, which was really an international meeting of MS experts from around the world. There were just over 30 people at that meeting in Grand Island, Buffalo, in 1982. Just last month was the global MS meeting that we have annually, this time in Milan. And there were 18,000 people there. So it shows the dramatic change, both in perceptions and in the reality of what can be done. As you say, modern imaging wasn't even a rumor at that time. We would ask staff to put patients whom we thought might have MS into a hot bathtub that was located on every neurology floor. And we then go in, and if symptoms or signs of disease worsened in the heat, if the symptoms were heat sensitive, we would say, well, that's evidence that this is multiple sclerosis. We'd rely on our clinical skills more than we do today to make the diagnosis of multiple problems in multiple places in the central nervous system. And we'd also rely on spinal fluid and on the detection of a chemical made by a type of immune cell called a B cell, an immunoglobulin molecule, to diagnose MS. But at the time, we were told that these abnormal immunoglobulins, called oligoclonal bands in the spinal fluid, yes, they were diagnostic of MS, but they were also completely irrelevant to the cause of the disease. And a large portion of my career over the last 45 years has been based on overturning that incorrect notion that antibodies, and especially the cells that make antibodies, are not important in the disease. In fact, we've learned over the years that B cells, a very rare white blood cell in the bloodstream and in our lymph nodes and other organs, 2% of the white blood cells in our bloodstream, are the central actors in orchestrating the tissue damage that happens in MS. They're the generals of the MS immune system.
So many of the people watching this are familiar with modern B cell depleting drugs, rituximab, Ocrevus, Kesimpta, Briumvi, but when you were first pursuing this, there was a lot of skepticism. I know you wrote in one place that the FDA didn't think it was biologically plausible. What convinced you that B cells could be important, and how did you actually bring the original studies to light, like the Hermes trial, the Olympus trial?
Yes, it began by bringing together laboratory investigations with bedside medicine and using each to teach and guide the other. Uh, my goal from the time I saw Andrea was to try to understand multiple sclerosis. And the models that were used at the time were basically models of vaccine complications that caused brain inflammation, but not the specific kind of inflammation that we saw in our patients with multiple sclerosis. Nonetheless, those early models were used to develop an understanding of what we thought was the mechanism of MS. And those models taught us that B cells had nothing to do with the disease, but that the disease was caused by a more common type of lymphocyte called a T cell or a thymus-derived cell. So the entire world, including I and myself, believed that T cells were sufficient to cause MS, just as they were sufficient to cause inflammation in these animals, usually mice. But the pattern of tissue damage in the mice was totally different. There was not the attack on myelin with an exploding myelin pattern that we saw in the tissue from people with real MS. So I spent more than a decade under the leadership of mentors who helped guide me along the way, developing a model that for the first time faithfully recapitulated the type of damage that we saw in real people with MS. But then when we tried to prove that T cells were causing this damage, the T cells caused the inflammation, but not the exploding myelin. It caused the damage that we had seen for decades in mice. And it was only when a group of fantastic young neurologists working with me in the laboratory came up with the idea that maybe it's not T cells at all. Maybe it's B cells and the chemical products that they make that led to the testing of B cells in this model. And we quickly found that B cells indeed were directing an immune response that led to exploding myelin, exactly the same as we saw in our patients. And then we went back to the tissue from real MS and also found B cells and their chemical messengers within the tissue. So it was the laboratory work built over a 15-year period that gave us hope that an entirely new direction of therapy focused on B cells might be useful. But this did go against the grain of the field at the time that still believed that T cells exclusively were responsible for disease. And this continued even after pure T cell-based therapies were shown to be ineffective. So scientists pivot slowly, as do all of us as people. And the NIH, the National Institutes of Health, which has to rely on expert witnesses, and the National Institutes of Health, which has to rely on expert advisors, thought that it was a far call to suspect that B cells were at the center of MS, even though this disease model in the laboratory pointed directly at that. So the NIH was not interested in funding B cell directed work. And ultimately, as I describe in the book, it was the leadership of great pharmaceutical companies that believed that high risk but potentially high value experiments needed to be done. And as the CEO of Genentech said before the first trial was green lighted, um, if we don't do this, what are we in business for anyway? So another goal of my memoir was to describe the importance of close and trusting relationships across academia and clinical neurology and patient populations with industry, with the pharmaceutical and biotechnology industry. And certainly those close relationships and high risks that all were willing to assume led to the breakthroughs that you described with rituximab and ofatumumab and ocrelizumab.
Yeah, and I think at the beginning, people were very reluctant to prescribe these drugs, but fast forward now, people are more aggressive, giving higher efficacy medications earlier in the disease. And, we're seeing a big difference. We're seeing people do a lot better, but there's still some people who aren't doing well, particularly people who may be a little bit older, have progressive MS, don't really make new lesions on MRI or have relapses. They may not necessarily have great results. What do you think we're missing? What do you think is the next step so we can help a higher percentage of people with MS?
Another lesson of all of the MS trials and research over the last generation is that we've learned more from the results of the bedside studies than we have from all of the laboratory work together. But we learn the most when the two worlds are brought together. And we did not understand that progressive MS was present in essentially all people with MS from the beginning of the disease until we could silence relapses with B-cell therapy and other highly effective therapies like natalizumab. And when we silenced relapses, we thought that progression would be silenced also, but it wasn't. And for the first time, we saw silent progression slowly percolating, even in people with early relapsing MS. And the effects were hard to measure at the bedside, but patients knew that they weren't quite as good year to year, even when the attacks stopped. Maybe they became dizzy when they kicked a soccer ball, or when they swung a golf ball, or maybe their energy wasn't as strong as it was, or they were having more trouble multitasking than they thought they should. So one of the great lessons of the success against relapsing MS, and B-cell therapies are more than 99% effective against localized brain inflammation measured by MRI. So they're incredibly effective against the inflammation part of MS. But we've learned that the progressive part of MS that results in brain degeneration, in neurodegeneration, is only partially helped with B-cell therapy. The beneficial effects are greater when we treat earlier, as you say. And maybe we block about 40% of the benefits when we treat early and 30% of the benefit when we treat later. But progression is still happening. And we've also learned by silencing relapse what the tissue damage causing progression looks like. And it has helped us to focus on two major types of damage. The first, where old MS scars continue to slowly worsen. And the cell that probably is the main culprit is called a microglial cell. And B cells, we know, are talking to the microglial cells because when B cells are depleted, when they're removed, these turned on microglia cells cool down. So that's one pathology. And the second pathology, to our surprise, was not even in the brain. It was outside the brain, in the meninges or the tissues that are lining our brain and spinal cord. And in these meninges are collections of B cells and other cells of inflammation that are making chemicals that are injuring brain cells underneath. So the field has now focused on understanding how residual immune cells that our therapies can't reach are causing damage in the brain and also activating microglial cells that are making old lesions worse. So focusing on therapies for those cells is the major impetus of modern therapeutics research. And then the other is low-hanging fruit. And it's possible that by treating MS at the dawn of disease more intensively and more effectively, maybe we can intervene before these other problems begin to percolate. So maybe we can cure disease initially by treating more ambitiously at the very beginning. And there are studies underway that are attempting just to do that. Can we cure MS by treating with B cell therapies or other therapies at the very beginning of disease?
Now, a lot of people ask me about Epstein-Barr virus. You mentioned in the book that you had a bad case of mono when you were younger, which doubles the risk of MS, and virtually every adult with MS has antibodies against Epstein-Barr virus. But recently, an immunotherapeutic ATA188, they announced that it was unsuccessful in a phase 3 trial. So, do you think EBV causes MS or is part of the causal pathway of MS? Is EBV therapeutics dead or is it still a dream?
Many of us thought that the EBV trial was more likely to fail than not, but we were all still praying that it was successful, of course. There is no question that Epstein-Barr virus plays an important role, along with genetics, in increasing risk for MS, and especially later exposure to Epstein-Barr virus and infectious mononucleosis, which often comes with later exposure in teenage years rather than during early childhood, is a clear risk factor for MS. But the simple idea that Epstein-Barr virus living in B cells, and Epstein-Barr virus lives only in B cells, that it's the Epstein-Barr virus in B cells that is causing the disease exclusively is probably incorrect. And it is more likely that Epstein-Barr virus is one of several triggers that increases the number and activity level of B cells and also T cells, other cells of the immune system, that then are cross-reactive, can also react with brain tissue. But by the time MS develops, the immune system has so amplified that it's moved away from that specific focus on Epstein-Barr virus exclusively. So it will be a very interesting experiment that someday will be asked, can we prevent MS from developing if we have an effective prevention vaccine against Epstein-Barr virus? We still don't know the answer to that, and that will be a fascinating question. My guess is that our immune system will find other stimulations that can also set the stage for MS to develop down the road. That Epstein-Barr virus is a particularly potent one, but it's not the only one. and other epidemiological risks are certain bacteria, especially a bacteria called Akkermansia, that has some proteins that resemble to the immune system Epstein-Barr virus, and that also resemble proteins of myelin. And even some of our normal immune system proteins have the same structure. So it may be that there are multiple routes to developing MS, of which Epstein-Barr virus is an important one, but maybe not the only one or even a mandatory one.
So maybe we would have to treat with the vaccine very early on because most people get exposed quite early in life. That makes sense.
Yes, I think that that would be the ultimate experiment. And there are debates now in the medical community about would population-based vaccination against Epstein-Barr virus be a good thing to do? And the arguments in favor are that there are perhaps 200,000 deaths each year from Epstein-Barr virus-related complications. So there are arguments on both sides that are quite strong. It's not only infectious mono that is an Epstein-Barr virus complication.
Yeah, I mean, there's Burkitt's lymphoma, nasopharyngeal carcinoma, and you could argue, hey, paralytic polio is only 1 in 400 people, and the rate of MS in the United States is 1 in 500, so it's a common enough disease to try to prevent.
Absolutely.
You,
Absolutely.
you briefly mentioned genetics, and I know you were involved in one of the major genome-wide association studies. Obviously, MS isn't strictly a Mendelian genetic disease, but there are genes that are linked to MS. Do you think that's important, and can we do anything with that information?
It's been extraordinarily important in terms of clarifying why some people are at risk for MS. But the genetic landscape of MS is, as you say, quite complicated. There isn't one dominant gene like there is for Huntington's disease or sickle cell disease. There are more than 230 genes that contribute to MS, and each one has just a tiny effect. But understanding how these genes work in people with MS has really helped understanding the important role of B cells and also the immune system in MS. And there was one very exciting discovery just this past summer by the international consortium that you mentioned that was responsible for really all of the genetic discoveries of the past generation. And this was the first gene that made MS more severe once MS began. And this gene, interestingly, doesn't work on B cells or T cells like MS risk genes do. It works on brain cells. And it probably influences how resilient we are to damage. As every MS physician knows, there are some patients with very mild MS symptoms and many, many scars in the brain, and people with just a few scars and severe symptoms. So we are able to fight inflammation in the brain in different ways depending upon the genetics that we've inherited. So I'm very hopeful that this new genetic region that has been recently discovered will lead to therapies that could be helpful against established progressive MS. It takes us into a whole new place for thinking about and understanding how progressive MS develops.
You mention in the book that as we have better technology and more treatments, sometimes we kind of lose the human side of medicine, the physician-patient relationship. And I definitely see that in my own experience. We're just so busy as clinicians. What do you think we can do about that to be better doctors?
I think it's the great challenge that we all face, how to maintain the spirit that we had at the beginning of our careers every day when we come into the hospital or the clinic. One story that didn't make it in the book, um, uh, hundreds of pages were cut as we tried to make the book more accessible. Um, I tell the story that as a medical student and resident, the hospital smell was so overwhelming to me as I would walk in every day. And then sometime over the course of my training, I lost the ability to smell the hospital smell. And we have to be so careful that we remember why we came into the field in the first place, and that our goal is to help people, not to help their disease only. And we have to remember what it was like for us when we're on the other side of the examining room. Uh, and I think that this is a challenge when we have to see 20 or 30 or 40 patients a day. Um, I personally think that we need to find better ways to increase the time that we can spend with individual patients and use resources that, we currently have very few limits on how many MRIs we take. We could, it seems impossible to me that we could have a healthcare system that makes MRI scans that at our institution cost $34,000 for a brain and cervical spine MRI, that we could order these forever without any checks. And yet we have to fight to get our patients in to see a physical therapist. And why do our visits have to be 20 minutes? Why can't they be an hour? So I think that these are some of the challenges that we face as a field, and that I really hope we'll find ways to repair down the road.
Well, one of my mentors, whom I'm sure you know, Leslie P. Weiner at USC,
Of
I worked
course.
with him at the very end of his career when he was in his early 80s. And I remember one thing he told me is, Brandon, you may not notice it over a couple of years because I was a fellow at the time, but over my career, over 40 years, we're definitely doing a lot better in our treatment of people with MS. On the average, there's a lot of variation. People are living better lives. Would you agree with that?
Absolutely. Absolutely.
So
It's,
on the lighter side, you talk about a lot of things in the book. You have a really interesting life, but you mentioned that your uncle Sandy was a boxer and you got to meet some of the old time great boxers like Jack Dempsey and Muhammad Ali. Do you have any interesting stories to tell about them?
I spent a lot of time with boxers, and then my uncle, who was really my second father, especially after my dad died young, um, uh, at one of the early HBO national televised prize fights, um, he, uh, during these professional fights, hundreds of people are coming into the ring, and the announcer has to say, and here's the former middleweight champion, Emil Griffith, and here is the former heavyweight champion, Leon Spinks, but it wasn't Leon Spinks. And it was an intruder who walked into the ring, and my uncle lost his job on the first HBO national telecast by insulting one of the former champions. So he had to pivot to wrestling for about a decade until he was brought back into boxing. And the wrestlers were even more interesting and exciting than the boxers to me. And I would spend my youth behind the curtain watching the bad guys and the good guys playing cards before they were going out for their battles, and then patching themselves up at the end of the fights. I think for both boxers and wrestlers, I was amazed at what warm, generous, kind, humble people they are. They're also very eccentric. and the whole community is eccentric. And I think that also helped me as a physician because um, I'm very comfortable with patients who may be um, less appealing to my colleagues because they're also eccentric people. So I think that my background and my family um, taught me to see people in all their cloaks in a different way than many other people who may have had a more privileged childhood could.
Well, you've had quite an amazing life and career. And hey, maybe you only have 30, 40 years left. So, what are your plans for the rest of your career?
Well, I want to see MS cured. I think that we can cure it. The low-hanging fruit is for patients whose MS is just beginning today. And we have a couple of studies underway that, fingers crossed, may begin to point the way to a cure. Our group has been thinking a lot about what we mean by cure. And for example, in another B cell problem, a malignant B cell disorder called leukemia, um, leukemia is treated very aggressively at the beginning and then is monitored. And if there's no evidence that the disease has recurred off of treatment for 3 years, patients are essentially cured. The risk of the leukemia ever coming back is less than 1%. And we're moving into that era for people with multiple sclerosis, and I think also for other autoimmune diseases, where we can begin to think of aggressive induction therapy as early as possible, and then maintenance therapy and monitoring and stop criteria. When do we stop treatment and continue to monitor? And then when do we declare victory? And I think we can begin to think about those scenarios in 2024. We can do that today. That would have been unimaginable in the 1970s. So that's one area of enormous hope that I feel. Another area is that by understanding now the cells and the genes that are driving progressive MS, I think we will have better therapies for people whose MS has been with them for decades and who have significant progressive worsening. And then finally, I think that there's an opportunity to develop, for the first time, truly effective repair therapies, therapies that can save injured nerve cells or regrow damaged myelin, and that could truly make a difference for people with disability today. There are also great opportunities to use stem cell biology and artificial intelligence and machine learning and computer-brain interfaces to find additional ways to help restore function in people who have lost function. So I understand that for people with MS that has caused significant disability, prospects sometimes seem bleak. But I think that answers are on the way. And it will be so important for everybody to understand that the future will be so much brighter if great young people who are interested in careers in medicine and science can be supported in a way that we can accelerate discovery in the future, because so much is possible today.
Well, I appreciate you taking the time. You definitely have a lot of words of wisdom. Again, everyone, check out the book, The Face Laughs While the Brain Cries. Again, I'll include a link in the description below. And good to talk to you. Take care.
Thanks so much, Brandon.